Hello and welcome to Leicester Children's Emergency Department. My name is Catherine and I'm one of the consultants here. This guide is aimed at trust grades, F2s and CT3s. If you are an ST4+, please refer to the other guide, which should be labelled as an ST4 guide. The aim of this talk is to welcome you to Leicester Children's Emergency Department and also tell you a little bit about our department, what it looks like, what you'll be doing here, what the opportunities are, and enable you to set some early goals. You'll be working as part of quite a varied junior doctor team. So the registrars might be paediatric registrars who are doing their EM subspecialty training, or emergency medicine registrars doing their paediatric subspecialty training. They also might be paediatric registrars just rotating through, or emergency registrars on their paediatric block. We have PEM people doing as an OP, including some of our education fellows, and we have CT3s from emergency medicine, FY2s, GPVTSs, people who are emergency medicine ACCS trainees, as well as specialty doctors and trust grades. All of you come from different places and have different skills, and we hope that we put this together to make a really effective team. As a department, we are a standalone children's emergency department, which means we are completely separate in terms of where the children are and where the children go. However, we're co-located with the adult emergency department. We share some of their staff. That means doctors, including consultants, nurses, HCAs, and obviously things like X-rays and CTs. Within the trust, we fall within the Emergency Specialist Medicine Directorate, and so we are linked very closely to emergency medicine. However, of course, whenever we admit patients, they're admitted to the Children's Hospital, and a lot of our guidelines, etc., are going to be the same as the Children's Hospital to ensure continuity. So we work very closely with them too. We are a tertiary centre, but we're also part of the local network, the intensive care network, the EM local network, and of course the trauma network. We like to think that we provide the best of both worlds. Normally, we're quite busy, one of the busiest units in the country, but of course COVID has completely changed our figures, just as it has for everyone else. So, patients can arrive to us in two different ways. They might walk in, or they might come by ambulance. If they're really sick, then EMAS will pre-alert us, and they might go directly to the emergency room and be treated as appropriate. If they're less sick, but they've come by ambulance, they'll be sent to the nurse coordinator, who will take them through the COVID sieve process. Those patients that walk in will go straight through the COVID sieve and then to be directed to reception, because everybody needs to be booked in to be put on the nerve centre system. As part of the COVID sieving process, they'll be allocated into blue or red. Blue is no COVID symptoms, and red is COVID symptoms or family isolating. Both the blue and red areas have an injuries and a major stream. And once they've been appropriately triaged as part of that stream, they'll need medical assessment, investigation and treatment. And this is where you come in. Hopefully, after all of those things, it should be possible to make a decision about where this patient needs to be. Do they need to go home? Do they need to be admitted? Or do they need to be transferred out for further treatment? And ideally, all of these things should happen within 4 hours. It is a little bit complicated. There's more than one route in, there's more than one route out, and it is possible for people to move about a little bit in the middle. The other thing is that you should know is that we operate a single front door here. What that means is all acute paediatric admissions come through A&E. And so we have a paediatric team based down with us here called the Children's Acute Team. That consists of a paediatric consultant, a paediatric registrar, physician's associates, and then some juniors who sometimes are FY1, sometimes FY2, sometimes GPVTS, and sometimes paediatric trainees at a junior level. We all work together and we have a single stream. Your role will be to see all or any of these patients. You'll be seeing the walk-ins, ambulance referrals. You may well be asked to help out in recess, and you may be asked to work in blue zone or red zone. Obviously, if you've had an occupational health assessment that says that you can't work in one of these areas, then please do let us know and we can allocate you appropriately. So on any day, you may well be seeing patients. You may be doing practical procedures with supervision as required. One of the things that COVID has brought is a lot more ketamine sedation. For those of you who don't know what that is, it's a form of sedation where a patient goes into a trance and we're able to do painful procedures like manipulating fractures. This can prevent admissions for theatre and is a really useful thing for both the hospital and for patients, because it means a short stay and then they get to go home. We're a big varied team and we all expect to work together. Supporting other staff means essentially doing what's required. One of the things that you might be asked to do is, for example, your own observations. In order to minimise people going into infected patients, it's good if while you're there you can write down the observations and the nurses can input them into a system. We might ask you to do things like give your own inhalers, especially if nurses are busy. So just be aware of what else is going on in the department and the busyness of other people. You may ask to help out in terms of supporting resuscitations. Obviously, this might vary a little bit depending on your skills and experience. We won't ask you to do anything you don't feel comfortable with, and if you don't feel comfortable with something, please do let us know. As a group, you all come from different backgrounds, and we are very familiar with the fact that some of you might have had specialist training before coming to us. If you've got a specific skill set, please do let us know. We've had people who've been opticians before. It's really great having somebody teach us how to really use a slit lamp. We don't have many hard and fast rules because it's a very dynamic environment, but any safeguarding concerns must be discussed with an ST4+. Now, you'll have heard on your safeguarding talk that about A forms, or if you've not seen that one yet, then you will hear about A forms. But if you are concerned about a patient and you have genuine safeguarding concerns, please do discuss that with a senior. If you feel that your concerns aren't being listened to or acted on appropriately, then do escalate it. That's okay. Anybody on their third attendance for the same problem must be seen by an ST4+. The reason for this is if somebody comes back 3 times with the same problem, we've either misdiagnosed it, we haven't treated it appropriately, or there's some kind of perceptual problem, and all of those need senior input. All children under 1 year must be discussed with an ST4+. All children under 3 months must be reviewed, physically seen, by an ST4+. Now that doesn't mean you can't see them, it just means, if, for example, you've got a little baby who comes in with a sticky tummy button because the cord's just dropped off and they're only, 10 days old or so. Those children are really high risk for getting interesting illnesses that present in unusual ways. So it's fine for you to see them, but they've just got to be checked over by a ST4+. And this is all to do with the risk stratification for children under 1 year and children under 3 months. The registrar should be expecting you to approach them, and certainly we as consultants are, so don't worry about approaching us. In the same way as we don't have many hard and fast rules, we don't have many jobs that need to be done on a daily basis, but the UTI folder is one of them. Children who have urine infections may need follow-up as per NICE guidance, and in order to do this we need to check whether they actually had one or not, because it's perfectly possible to get symptoms and not have a UTI, and also not to have symptoms and then have a UTI. Both require investigation. So that lives in the office. It's fairly self-explanatory. Please come and find somebody if you're having any problems with it. Don't panic, okay? We might be busy, we might be seeing sick children, but you're never alone. So although you'll be seeing children independently, there's always somebody to ask. If the child looks sicker than you expected, then please do come and find somebody. You may well be right, they may well be sicker than expected, because children can deteriorate relatively quickly. And if you're not, that's okay. We'd rather always be asked. And of course, there's a whole range of other people you can ask. So there's a children's acute team. There's PICU we can get involved if we really need to. And of course, there's a doctor in charge next door as well. If you are having problems, please say, find a consultant on the floor, bring it up at handover, or just contact one of us. All of you will have been allocated a supervisor. So if you're struggling with something or there's a recurrent issue, then it's much better to talk it over and maybe we can solve it together. I hope you have a great time working with us, and I look forward to seeing you on the floor.